And today we're going to be discussing Medicare coverage within diabetes. So this is going to focus specifically on Medicare. Many of you may have Medicare. Many of us will have Medicare in the future, hopefully. Or you may be caring for someone or have family members that have Medicare. This is what we're going to focus on specifically, how to navigate Medicare coverage when we think about our diabetes management. With that, let's talk about the objectives for our webinar today. We're going to understand the basic framework of Medicare. We'll take a look at the prescription coverage framework specifically, especially for common diabetes medications that are covered under Part D. We're going to identify coverage requirements for diabetes monitoring supplies and technology, and we'll summarize current price incentive programs for prescription medications under Medicare. So we'll get started with that first section, taking a look at the overall Medicare structure. So just as a very basic baseline, what is Medicare? So Medicare is a federal health insurance, and it's primarily for anyone over the age of 65. However, you can qualify for Medicare if you are younger, based on certain disabilities, most commonly end-stage renal disease or kidney disease requiring dialysis or transplant, as well as ALS. It's important to know the ABCs of Medicare and the different parts, as they specifically are tied into what covers, what services. Um, these are the three main parts of Medicare: Part A, Part B, and Part D. Part A and B are often referred to as original Medicare. Part A specifically covers hospital insurance. It's like your inpatient hospital stays, anytime you're inpatient, skilled nursing facilities, hospice care, certain home health care. That's where you see your Part A going to work. Part B is what I would term medical insurance. It covers outpatient care. You go to see your primary care doctor. It also covers durable medical equipment. So you see bolded here, glucometers and CGMs would fall under durable medical equipment, as well as certain other things that we use in diabetes. Preventative care is covered by Part B, including certain vaccines, not all, but certain ones, as you see here listed. The flu vaccine, pneumonia vaccine, Hep B, COVID-19. Certain medications are also covered under Part B, mainly medications that require some sort of technology for administration, like an insulin pump, or medications related to end-stage renal disease, for example. There's sort of a hodgepodge list of seemingly random medications covered by Part B. Now, Part D is what we're going to focus on a lot. As a clinical pharmacist, this is where I interact with insurance a lot, and that's prescription drug coverage. So Part D only covers prescription drugs and a few associated things with those prescription drugs, like a insulin pen needle, for example, as well as vaccines that are routine and not covered by Part B. So you can see drug coverage in Medicare is spread over technically two different parts, although you could say 99% of the drugs are covered by Part D, and there's just a few select drugs covered by Part B. Other parts of Medicare to be aware of: Part C is what we call an advantage plan. So you may be familiar with Medicare Part C. I didn't list it above. Where did it go? So Part C is not actually its own thing. It's more a combination. Part C and Advantage plans basically combine Part A and B, your original Medicare, your inpatient and outpatient insurance, along with Part D or your prescription insurance. And you may have some additional benefits in your Advantage plan, depending on which one it is, that aren't covered in sort of the A and B original and the D standalone Part D prescription drug plan. So Part C is your combo, sort of all-in-one plan. I have one card. It shows my insurance for my doctor, but also my pharmacy, and maybe a few additional benefits. There are also things called Medigap Medicare supplements, and there are many of them. This is essentially extra insurance you can buy from a private health insurance company to help pay your share of out-of-pocket costs in original Medicare, as well as a few other things. I will caveat there's a ton of different types of supplemental plans. I'm not going to focus on them because it really depends on which one you get as to what you're going to receive. A majority of them do not cover medication cost. To illustrate the point further, you can see the different types of Medigap plans, starting with Plan F. Then you see G, K, L, M, N, what it does cover, what it doesn't cover, um, etc. So again, today we're primarily going to focus on Part D. We will cover a little bit about Part B. So that's our overview of overall what is Medicare, how does that coverage work. Let's dive specifically now into prescription coverage. This is why I'm here as a pharmacist. So Medicare Part D has a specific type of structure. Your Medicare Part D plan is sponsored by some sort of company. The most common ones are like Humana, United, Cigna or HealthSpring, AARP. Those are all sponsors, but overall, they have to play by the rules of Medicare Part D, which is set, by law by the government. So your AARP Part D plan is Medicare. It just has a private sponsor, and it has to follow these rules. So Part D plans use a three-phase structure. The first phase we call the deductible phase. In the deductible phase, you are responsible for 100% of the cost of your drug until you clear that deductible. A few caveats to understand. The max standard deductible in 2026 is $615. This is the most common deductible. Now, you may have a very good plan, or maybe I should sort of reterm that you may have a very expensive plan that has a lower deductible, but the max that it can be and the standard is $615. Now, the deductible really only applies to brand name drugs. So if you have only generic drugs, you probably never had to pay your deductible. But if you have brand name drugs, you would first have to pay your deductible, and then you would move into the second phase. That's initial coverage. And that basically refers to whatever coverage your plan provides. So if your plan has a flat copay, meaning every drug in this tier, let's say tier 3, is $45 per month, that's what your coverage is after the deductible. Also, initial coverage can be done via a coinsurance style. This is much more prominent the last 3 years, and why potentially people see higher costs when they go to fill it at the pharmacy. And the difference between copay and coinsurance is copay is a flat cost. Coinsurance is a percentage of the cost of the drug. So some insurances say all tier 3 drugs are $45. That's a copay style initial coverage. Most insurances, though, will say the patient is responsible for 18% of the cost of the drug for these list of drugs. That is coinsurance, meaning how much you pay directly depends on the retail cost of the drug, and you pay some fraction of that. Now, in 2026, if you pay $2,100 in out-of-pocket expenses, you will reach the catastrophic coverage phase. And in that phase, after spending $2,100, you will have no cost share, meaning every other covered medication for the rest of the calendar year will be free. Okay, Medicare works on a calendar year basis. That's why we see high costs in the beginning of the year, especially if your deductible is reset, and why you see lower costs at the end of the year if you've reached your catastrophic coverage cap. So if I reach my $2,100 expense cap in July, the rest of the year, if I'm getting a medication that's covered by my insurance, it's free. Of course, this does not apply to medication not covered by insurance. Some important notes, the deductible is part of the $2,100. Now, technically, you don't actually have to pay the full $2,100 to reach your catastrophic coverage cap. Under Medicare Part D, there are essentially two types of plans. Now, you may not know which type you've had. It doesn't usually define it in these ways, but based on the type of coverage you have, you can split plans into two. There is a defined standard type plan and an enhanced alternative type plan. A defined standard plan just means you have a bare bones plan. Often these plans have $0 monthly premiums or very low cost monthly premiums. And essentially, that means you have the minimum coverage by law. So you would have a full $615 deductible if you're going to be getting brand name drugs. Your coinsurance on most commonly used brand name drugs would be 25%. That's the most that it can be outside of some specialty tier medications that are a little bit rarer. And you would pay every dollar and cent of the $2,100 cap before hitting that catastrophic coverage phase. Now, I would say in my experience, most people actually have an enhanced alternative plan. They don't know this, but they do. And the way you can tell if you have an enhanced alternative plan is because either your deductible is smaller, very rarely is it zero, usually it's some fraction, maybe it's $300, not the full 615. And or you have a reduced cost share, meaning instead of paying the max 25% for the cost of the drug, maybe you only pay 18%. Or maybe you have a flat $47 copay. And so those are enhanced alternative plans. Now, if you have an enhanced alternative plan, what actually ends up happening is you don't have to pay the full $2,100 before you reach your catastrophic coverage cap. And that is because the way they calculate your out-of-pocket cost under Medicare Part D all depends on that standard. I know that sounds a bit confusing, but let me illustrate sort of an example that might give you an idea of what I'm talking about. Let's take two different types of enhanced plans. They both have a $615 deductible. Plan A has a $47 copay for Ozempic and other tier 3 drugs. Plan B has a 16% coinsurance for Ozempic and other tier 3 drugs. So if we say Ozempic on retail level costs $1,000 cash price per month, which is about what it costs. And the defined standard we just talked about is 25%, right? That's the most insurance can make you pay for this type of drug. So 25% of 1,000 is $250. For the plan A person, they will only pay $47 because what we just saw is that's the plan A. That's what it offers, a $47 copay for this drug. And in plan B, we had a 16% coinsurance. 16% of 1,000 is $160. So the person in plan B will pay $160. But what actually counts towards your out of pocket? What counts to that $2,100 limit? In both cases, it's still $250 because what actually counts towards your catastrophic coverage cap is the standard. So if you have an enhanced plan, what will happen is you will reach your catastrophic coverage cap before physically paying the $2,100. And this table is an example of that. If we take that $47 plan I just talked about and we apply that payment throughout the year, that first payment will be $662. That's your deductible plus the coverage of the drug. After that, it's $47 a month. You've cleared your deductible. And you can see in July, it goes to zero. And that's because if you calculate the cost that's been accruing based on the sort of the standard plan, that 25% coinsurance, at that point in July, this person would have reached $2,100. But they have an enhanced plan. When the standard has tallied to $2,100, the enhanced plan only tallied to $945. That doesn't matter. And so when you have an enhanced plan, you won't physically fully pay that $2,100. The caveat to all of this is most enhanced plans will cost more per month. So it is a bit of a balancing act when you think about your total annual expenses in terms of how much am I willing to pay for medication out of pocket because I have an enhanced plan, I might pay a little less, versus how much am I paying the insurance monthly for my premium. Sometimes it makes sense to go with worse coverage if your annual total expense, when you think about that premium, is actually less than choosing the really fancy good coverage plan. So this is a very important concept to understand to help you think about and even predict what my annual expense of medication will be. Now, in diabetes, there's a number of different medications that we use. There's maybe 6, 7, 8 different classes of medicine as a whole. Some of them are low cost and generic. Some of them are very costly because they're brand name drugs. And then we also have insulin, which sort of has its own rules. So we think about low cost generic drugs in diabetes. Mainly we think about metformin, think about sulfonylureas and meglitinides, glipizide, glimepiride, repaglinide. These are all common drugs in that class. And we think about something like pioglitazone, or used to be known as Actos. When we think about high-cost drugs, we're thinking about brand name drugs. Most commonly, what we're thinking about is Ozempic or Mounjaro. Jardiance or Farxiga, Januvia or Tradjenta. The GLP-1s, SGLT2s, and DPP-4s are the most expensive drugs when we think about diabetes management commonly because they are brand name only, especially with Medicare because of that deductible phase. And then you have your insulin options. There is a number of different insulins, long-acting, fast-acting, mixed. There's even mixed insulin GLP-1 products, and those fall under its own class where by law, as a result of the Inflation Reduction Act, insulin is $35 for a 30-day supply. So diving a little bit deeper into the low-cost generic options, the three that we saw, metformin, pioglitazone, and the sulfonylurea class, things like glipizide and glimepiride. These medications are generic, and so they do not require you to pay your deductible, which is why if these are the medications you use and only these medications, or previously you only used them, you know that generally very well covered, generally considered affordable. There's no sort of surprise bill in the beginning of the year because of a deductible phase. And so there's usually not much issue with these medications when we think about getting them covered under the pharmacy. However, if you're someone where for some reason the insurance is not covering it, or perhaps you don't have Part D yet and you're hearing, oh, these are low cost, but without insurance, they're very expensive. There are some options you can consider if you feel like your cash price paying for them will be better than what your insurance is giving you, or if you potentially have no prescription insurance. It is possible to be in Medicare and have A and B and no Part D. In those cases, some great places to look for low-cost generic medications are, for one, Mark Cuban's Cost Plus Drug Company. They're a mail order pharmacy. You have your doctor submit the prescription to them. They will mail the medication to you. They only have generic drugs on their website or at their pharmacy. And you can go on their website and find that exact cost. They add $5 for shipping. It's pretty transparent. And I will say for most generic medications, if you are not getting a good deal from your insurance, it's a great place to check what they're offering. Just remember the quantity of how many you need, because that obviously will affect the cost. Walmart has what they call the $4 list, although I will say not many medications are $4 on there anymore. They can be 4, they can be 10. If you want a 30-day supply, they can be a little bit more. But generally, a very competitive price, cash price for generic medications. And if you're local to the Bay Area, there is something called the Better Health Pharmacy. This is ran by Santa Clara County. And they are a pharmacy that runs off of donations. And you can get your medication there for free with your prescription. They do have a very limited inventory. You can check that inventory online. And even if it is in their inventory, it's not a bad idea to call ahead because, again, their supply is dependent on inventory or on donations, sorry. So a great place to look if you feel like you are not getting a fair shake on your generic drug cost. Typically, we don't see many issues here with these medications. The problem comes with the high cost and brand name medications, which is very unfortunate because these are also some of our best medications with the best evidence and efficacy. So when you think about GLP-1 receptor agonists, which are sort of all over the news these days, Ozempic, Rybelsus, Mounjaro, Trulicity, these are our most commonly used GLP-1 receptor agonists in diabetes. Their prices differ, but you can say around about $1,000 for a 4-week supply, which is very expensive. The second class of medication are the SGLT2 inhibitors. Most commonly in this class, we have Jardiance and Farxiga. And they used to be a little bit more pricey. This year, they're cheaper, and we'll go into why that happened. They're about $180 to $200 for a 30-day supply. Again, I'm not going to call them cheap, but not $1,000. And lastly, we have our DPP-4 inhibitors, things like Januvia and Tradjenta. Again, they are on a price negotiation program. So right now they are down to about $115 for a 30-day supply. But certainly more expensive than the medications we talked about in the previous slide. Now, some things to remember and about brand name medications and these high cost medications, and really why there's a problem, is that your initial coverage on them, whether it's coinsurance or copays, will only kick in after you've cleared your deductible. And again, the max standard deductible in Medicare is $615. That's not a small amount. So that is part of the reason it's so difficult to afford these medicines, that they have that deductible tacked onto them. Now, when you have one or more brand name medication that you take, and to be honest, taking, something like Jardiance and Ozempic at the same time is incredibly common, you may reach your out-of-pocket max, that $2,100, much faster because naturally, you're spending more money on medicine and that medicine is quite expensive. And so that is something to consider in the sense that if you're going to be hitting your catastrophic coverage cap with just Ozempic, adding on something like Jardiance will actually not change your annual expense. And so when you start dealing with multiple brand name drugs in your regimen, the cost does not necessarily increase linearly. Another thing that we will get into a little bit later, but is important to consider with high cost medications, is the Medicare prescription payment plan. And this is an option available to all members of Medicare Part D plans or Advantage plans that have prescription coverage, where you can spread the cost out of your medications and avoid very large lump sums at the pharmacy. The last class that I pointed out in our sort of start to this section is the insulins. Now, you can see a number of different types of insulins down under. You can see insulin glargine, Tresiba, Novolog, Humalog. These are all the most common insulins. Your plans don't cover every single insulin. Most plans will cover some long-acting options, some short-acting options, some mixed options. The key for insulin and cost is to find which brand your insurance prefers. And when you find that brand, that cost will be $35 for a 30-day supply. Now, most of the time, insulin is not ordered in 30-day supplies. So you may be seeing, Michael, you're saying it's $35, but actually it's like $80 when I go to the pharmacy. That means that it's a longer supply. So if it's $70, it's $60 supply. If it's $105, that's a 90-day supply. So $35 per 30 days is a rate, and you can calculate out how much it will cost if you know the day supply that was sent to the pharmacy. One thing that not a lot of people know is that if you're someone that really wants to use a GLP-1 or may benefit from a GLP-1, of course, you need to talk to your team about if that's appropriate. And if it is, but it's very hard to afford, uh, and you're already taking insulin, there are combination products, insulin and GLP-1 combination products, and they fall under the insulin pricing. The nice thing about the insulin pricing is that it doesn't require you to pay your deductible before you get that $35 cost. So right from January, the insulin is $35 per 30-day supply. Again, you may be asked to switch to a different brand. Almost every single insulin has a equivalent different brand or generic or biosimilar. That's the key. But after you do that, $35 for 30 days. Let's switch gears for a second and cover Part B before we get too lost in the weeds on Part D and talk about the coverage of glucose monitoring supplies and certain technologies. If we go back to our Medicare ABCs, recall that under Part B, we have our durable medical equipment benefit. Glucometers, which are like finger stick glucose meters, and continuous glucose meters, the CGMs, the sensors that are worn on the arm, those are all considered durable medical equipment. They are all covered by Part B when you think about Medicare. Now, the one caveat to this will be if you have a Medicare Advantage plan, which again combines A, B, and D, they may process it as a pharmacy benefit, but because you have a Medicare Advantage plan, it's sort of all a wash because you just have one combined giant plan. But if you don't have a Medicare Advantage plan and you have separate A and B and separate D, so original Medicare plus some sort of Part D standalone plan, those glucometers and CGMs are covered by Part B, not the Part D plan you chose. The most common things we think about is glucometers, CGMs, and also insulin pumps. Most insulin pumps, not all, are going to be under Part B. And the insulin you use for an insulin pump will also be under Part B. Now, if you're using insulin without an insulin pump, that's just under your Part D plan. When we think about glucometers, they are the most cost-effective way to check sugar. In diabetes, checking your blood sugar is incredibly important. Yes, we all get A1Cs done, but A1Cs are sort of more long-term metrics, 3-month averages. Checking your blood sugar really gives you your current day-to-day understanding of trends and sort of shifts in your blood sugar. Medicare Part B will cover 80% of the cost of these for patients with diabetes. Now, where this gets tricky is test strips. I'm sure many of you have heard or have experienced personally that test strips can be difficult for coverage. And that's usually where the cost racks up when we think about glucometers. The glucometers themselves are generally cheap. It's the recurring test strip supply that can become pricey. One thing that's very important to understand is essentially, if you're not using insulin, Medicare will only approve you to test your blood sugar once a day, which means they will only cover one test strip per day. If you are using insulin, they can cover 3 times a day or potentially more. Now, there may be exceptions to this rule. It will require your doctor to write some sort of authorization and go through a process. But generally speaking, this is the coverage limit that Medicare sets. There are a number of different glucometers. All of them are pretty much the same in terms of they all will read your blood sugar accurately. Some common brands that we see coverage for are One Touch, Freestyle, and AccuCheck. But I would encourage you to use whatever is covered so you have the most cost-effective way of checking your sugar. And I would encourage you to get prescriptions for sort of a generic glucometer and have the pharmacy check with your insurance what's the preferred brand and dispense that one. Just remember your strips have to match your glucometer, otherwise, the strip's not going to work. Now, a lot of the times, the test strips, even with insurance, can be expensive because, again, Medicare Part B will only cover 80%. If you have a supplement, they might cover some of the residual costs, but if not, potentially it could be expensive. Or maybe you're someone that wants to check your blood sugar more often than Medicare is providing coverage for. You do have some options in terms of paying cash. So what do you do in that case? The most affordable glucometer that I know, if you think about cash price, is the Walmart brand Rely On. This can be prescribed or picked up over the counter without a prescription. I have the links here, so when we post the slides, the links, unless the URL changes in the future, should be active. But the Rely On Premier Classic glucometer is $9. That's a one-time expense generally. The Rely On Premier test strips are $19 for 100, which is usually much better than other ones that can be $50, $60 for 100. That's your recurring cost. And Lancets, the little things that poke your finger, those are about $2 to $3 for 100. So that's another recurring cost that's very low. So definitely an option if you are not getting good coverage for your test strips, not getting enough coverage, you could supplement with the Rely On brand. This also happens for people on CGMs. If you're on a continuous glucose meter, they may not cover a lot of test strips. And so a good option is supplementing with an effective cash solution. And that brings us in a good segue to the CGMs. So CGMs are continuous glucose monitors. If you see people wearing sensors on their arms, that's what that is. These are sensors that measure the sugar every minute to 5 minutes. They trend your blood sugar over the whole day. They alert you to highs and lows. These are excellent tools to understanding glucose patterns. A lot of the times we focus on numbers, but to be honest, patterns are incredibly important to understand because they will help us understand how to potentially tailor your medication or potentially focus in on certain lifestyle factors, identify things that work, identify things that don't work. I highly recommend people with diabetes try to use a CGM. Now, what usually stops that recommendation is coverage because these are not, I would say, cheap pieces of technology. Medicare Part B will cover 80% of the cost of CGMs if you have a diabetes diagnosis and you're using insulin. The only way to get around the insulin requirement is if you can show that you've had multiple instances of what would be called a hypoglycemic event or a low sugar event, where you have recorded documentation the blood sugar was under 54. This is, I'm not going to lie, a little bit difficult to push through in terms of coverage. You have to have very clear documentation of this happening, which is why I typically say if you're not using insulin, it's very unlikely Medicare will provide you with a CGM. Now, there are different types of CGMs on the market. Prescription CGMs, one that require a prescription from the doctor. The most common are Freestyle Libre 2 Plus and 3 Plus, as well as Dexcom G6 and G7. These are excellent products. In terms of getting them from the pharmacy, with Medicare, even with insulin, it's a bit of a process. We have to prove that you have a diabetes diagnosis, prove that you're taking insulin. There's a number of questions your doctor has to answer. And so I usually recommend people ask their team to send it to a durable medical equipment supplier. These are like pharmacies, but for equipment. Suppliers really know how to work through that paperwork efficiently, and things get done much faster, in my opinion, than just going to a retail pharmacy. So highly consider this if you've had trouble getting a CGM, even if you've had a diabetes diagnosis and are using insulin. Now, there are other technologies to consider. There are also over-the-counter CGMs, although I don't recommend their use if you have a diabetes diagnosis because they're lacking important features like low blood sugar alerts. But there are other things to consider too. We talked about insulin pumps. These are usually covered by Part B. I will say one caveat is Omnipod, especially Omnipod 5. It's a very popular tubeless insulin pump that is actually covered under a pharmacy benefit. As far as I know, it's essentially the only pump under Part D. And so it will be governed by those Part D rules we talked about earlier. Other pumps, though, under Part B. There are also things like secure insulin patches. This is a patch that you see on the right here in the image where you fill it with short-acting insulin. You wear it on your abdomen, you click it, and it delivers 2 units of insulin per click. Great if you don't like consistently using a pen. And then again, something like that would likely be covered you would think be covered under Part B, but actually covered under Part D. So with technology and supplies, most commonly, ensure your pharmacy is running it under Medicare Part B to get your coverage. But remember, there are strict requirements in terms of are you taking insulin or you're not? How many supplies is that gonna allow me in terms of coverage? Okay, let's talk a little bit about some more recent developments in terms of Medicare drug coverage, specifically the Drug Price Negotiation Program and Most Favored Nation pricing. So the Inflation Reduction Act, passed in 2023, allowed the Center for Medicare Services, CMS, which governs Medicare, to negotiate the cost of certain drugs that don't have generic or biosimilar competition. Very importantly, it also said that any drugs participating in these programs have to be covered by Part D plans. So if the drug has this negotiated discounted price, whoever is sponsoring the Part D plan, it has to be on their coverage list. Here's a timeline of that program. So in 2023, the law passed, and in 2024, the first 10 drugs to participate in the program were selected. There is always a 2-year gap between when the drug is selected and when that price goes into effect. So the drugs selected in 2024 and their prices published in 2024 have gone into effect this year in 2026, where this is the first year where it's happening. Last year, they selected 15 drugs for 2027, and those prices were published at the end of last year. And then this year, we will be choosing drugs for 2028, or the government will be choosing the drugs for 2028 cycle. For the 2028 cycle, it will include some drugs that are covered under Part B. So if you take Medicare, drugs that are covered by Medicare Part B, perhaps it will be on the list. These are the 10 drugs that have been selected for 2026. These are very common drugs. And when you look at from a diabetes perspective, you can see there are 4 medications on here that are very commonly used. Farxiga and Jardiance, which are SGLT2 inhibitors. We talked about them as high cost, commonly used medications. Januvia, same thing. DPP4 inhibitor, commonly used, typically high in cost. And Novolog, which is an insulin. I will say on the Novolog front, it's great that it's part of this program, but because it's also part of the $35 insulin rule, it's really not that much of a bonus. This is a comprehensive list of the discounted price, the 30-day supply for cash price before the negotiations and the ones this year after negotiations. The ones that we're highlighting, the not grayed out ones, those are the ones related to diabetes. And specifically, when we're thinking about commonly used medications like Jardiance and Farxiga, these are maybe medications that you've discussed with your doctor that before were incredibly expensive. They were about $500-$600 for a 30-day supply cash price. Now have dropped to $180-$200 cash price. Again, we're not talking about the covered price, it's the cash price. But what's important to understand is most people will have a coinsurance style coverage. what we talked about at the beginning, which is where you pay a percent of the cost of the drug. So actually, the retail cost of the drug really matters. If your payment with insurance is a percentage of the retail cost and the retail cost is down 70%, then also your copay will be down 70%. So when you look at Farxiga, so that's that first bold, not grayed out medicine, very common diabetes medication. The retail cost this year is $182. That's a cash price for 30 days. Compared to 2025, which you see to the right, it was $570. In the green is 25% of the cost of the drug this year. That's $45 per month. In the red is that same 25%, but last year when the drug was not part of this program. So last year would have cost us $140 to fill this for 1 month. This year it would cost us only $45 to fill for 1 month. So all of the drugs that participate in this program, their cost being directly affected on a cash price will also directly affect how your insurance covers them in terms of how much you will pay. Because most people will have a co-insurance style coverage that is directly impacted by the retail cost of the drug. So here's another way to illustrate this. Here's a SilverScript Choice plan. This is a standalone Part D Medicare plan. On top, you have a 2025 description of the plan and its coverage for Jardiance, and at the bottom, this year, 2026. The red arrow is pointing to the fact that last year, this drug under this plan had an 18% coinsurance, which cost $110 per month to fill after the deductible. This year is the same exact coverage, 18% coinsurance, but because the retail cost of the drug is down, it's only $37 per month. So here we have the same plan, which uses the same style coverage, a full deductible, last year $590, this year $615. Same style initial coverage after the deductible, 18% is what the patient has to pay. But because of the drastic sort of decrease in the cash price as a result of the drug price negotiation program, the fill cost after you clear your deductible went down from $111 to $37. And when you look at that annually over the whole year, so on the left, 2025, on the right, 2026, last year you had a very expensive fill up front because the cost of the drug was $600. You had a $590 deductible. The drug is more expensive than the deductible. That means you have to finish the deductible in one go. And after you finish it, it was still expensive, $110 a month until in December you reached your cap. That patient had an 18% coinsurance. That's an enhanced plan. They paid $1,600 for just Jardiance, not including any other medicine. In 2026, that exact same patient using the exact same plan now will have a longer deductible phase because the cash price of the drug is cheaper than the deductible, meaning it will take multiple months to clear that $615 deductible. But after they clear it, each month is only $37, roughly. And when you look at the bottom, the total, for the same drug, same style coverage, this year it's going to be $700 less to fill that drug through insurance. And that's directly a result of Jardiance being on the Medicare drug price negotiation program. So very important to keep an eye on which drugs are on this program. There are a number of diabetes medications on this program because it will directly impact coverage. This is the list for 2027. There's actually 15 drugs, so there's 2 slides on that list. Again, I want to highlight 3 drugs. Janumet, which is a DPP-4 inhibitor mixed with metformin, Tradjenta, another DPP-4 inhibitor, and Ozempic, and in all forms. So semaglutide is the generic name, Ozempic, Wegovy, and Rybelsus is all the same drug. Those are the 3 drugs on the 2027 cycle that will have their price discounted. Specifically, I really want to key in on Ozempic and Wegovy, Rybelsus, all forms of semaglutide. Right now, as we said, the cash price for a 30-day supply is about $1,000. So before the negotiations in 2024, it was $959 roughly for a 30-day supply. Post-negotiations in 2027, the cash price will be $274. That's a 71% difference. And again, when you apply that 25% coinsurance logic, that means that after the deductible, right now, people are paying about $250 a month for Ozempic. In 2027, at 25% coinsurance is going to be more like $65, $70. This is very, very different. These are very different numbers. And so for anyone that's considering Ozempic or had a discussion about Ozempic with or Rybelsus with their provider, but felt it was very expensive this year, next year it will be definitely different and is something to consider. A quick word on most favored nation pricing, also known as MFN. This is related to a recent executive order from 2025 that was aimed at lowering the cost of prescription drugs. And there were two very public agreements made with Eli Lilly and Novo Nordisk. Now, if you read the executive order, it's said to affect Medicare and non-Medicare patients. For non-Medicare, this is the only time I will talk about non-Medicare related issues today. The pricing that this most favored nation pricing is supposed to be viewable at Trump RX. You can see a number of medications that are used in diabetes or adjacent conditions and what they're supposed to be. Now, this actually rolled out last week, and it's now live. Again, this is non-Medicare, and it's termed as an official government website that connects patients directly with the best price for medication. So it's basically a repository of discounts for certain drugs. They do not sell drugs themselves. It compiles just a list of those discounted prices. Very important to note, it excludes Medicare and Medicaid, which is a bit unfortunate because, to be honest, that is where we see Medicare, especially, a bulk of the difficulty with affording medications. So very explicitly, when you look at the terms and conditions of the offers available on Trump RX, it will say that this is offers only available to patients with commercial insurance or who are paying cash. Patients enrolled in Medicare, Medicaid, or other government-funded healthcare programs are not eligible. The other thing I want to point out about this is the discounts they're offering are available and have been available on manufacturing websites. So although we're focused on Medicare today, if you're someone that doesn't have Medicare yet, or just wondering how things work outside of Medicare, most plans cover Ozempic on some level. If they don't, you could visit Trump RX, but those same discounts have been available through just Ozempic's website, and that's what I'm showing here. So you see here they're offering a $200 cash price for the low dose. Same here at Costco, and that's exactly what Trump RX is offering. Now, in terms of most favored nation pricing for Medicare, the timeline of when these changes will actually occur is unclear, but what the executive order proposes is a reduction in certain medications, specifically Ozempic, Wegovy, which are the same thing, semaglutide, and Mounjaro and Zepbound, which are both tirzepatide. So one form is for diabetes, one form is for weight loss. Those will be capped at $50 a month if your plan covers them in Medicare, kind of like an insulin $35 cap. More importantly, because the price will be reduced, it will actually allow Medicare to cover things like Wegovy and Zepbound, which are not diabetes versions of medicines, but obesity-related versions of medications that we use in diabetes, which are currently not really covered by Medicare. And it also says that if you're someone that has a plan that doesn't cover these drugs, but you have Medicare, the cash price will be $245 a month. Now, again, on all of these promises, the timeline is not clear. It could be 2027. It potentially could be like maybe July of this year. When there's more information, I'm sure we'll provide it. But at this point, it's not clear when this is rolling out for Medicare patients. The other thing to think about is we just talked about how semaglutide is on the 2027 drug price negotiation program. And so what this executive order is proposing is that if you have Medicare and you're seeking, for example, Ozempic coverage, it would be $245 a month if the plan wasn't covering it, $50 a month if it was. But in 2027, with Ozempic being on the drug price negotiation program, its cost will already go down to $274 per month, and at 25% coinsurance of that is $68 a month. So in 2027, the difference between MFN pricing and the regular Medicare pricing because of this program will not be very different. Now, if this program rolls out before then, that's great because we will have, a number of months where the price will be reduced ahead of time. Also, if the program actually reduces the cost of some other drugs that are not on the Medicare Drug Price Negotiation Program, things like Mounjaro and Zepbound and Wegovy, then perhaps we'll get a win there in terms of more affordability on drugs that are not covered at all. Lastly, I want to really quickly talk about the Medicare Prescription Payment Plan, or the M3P. This is also as a result of the Inflation Reduction Act. It's available to all Part D patients. There is no eligibility. If you have Part D or an Advantage plan that has drug coverage, you could apply to use the Medicare Prescription Payment Plan. It applies to all pharmacy types. It doesn't matter where you get your pharmacy, doesn't matter who you are. If you have Part D, you can use this program if it's beneficial. What it does is it allows the person in Medicare to spread the cost of their medications over the entire year in a monthly fashion, where you pay the insurance directly and you pay nothing at the pharmacy. Essentially, the insurance pays the pharmacy and then they bill you on some sort of monthly schedule with some sort of monthly fee. Now, this does not save anybody money. You do not save money through this program. You simply distribute it in a more even way, potentially. It doesn't change how fast you reach the coverage cap or clear your deductible or anything like that. It doesn't alter what goes towards the out-of-pocket maximum. It simply distributes the cost, and there's no penalty for that distribution. You have to opt in if you want to use this program. The pharmacy can't do it. You can't do it at the time of picking up medicine. You have to call your insurance or go to your portal or send them a form where you enroll into the Medicare prescription payment plan. When you do that, again, you will directly pay your insurance. They will send you a bill. You do not pay anything at the pharmacy, and the pharmacies are paid by your insurance. Who is actually going to benefit from this? Anybody with a very large, sum of money to be owed at the pharmacy, usually related to deductibles in the beginning of the year, and you don't want to pay that entire cost right away, or it's very difficult to pay that entire cost, this could be a good option. Now, something to think about in terms of the fact that this program is rolling into its second year, and you may have already been using it, is that if you were using it last year and you want to keep using it and you've kept your plan, you don't have to do anything. You'll automatically enroll. If you switched your plan, then you have to re-enroll. So if I was with Cigna and I was on the M3P and now I'm moving to Humana, Humana doesn't know what I was doing with Cigna. They will put me in a sort of regular pay at the pharmacy style pickup. If I want to be in the M3P again and I've changed my plan, I need to re-enroll. So again, when you go to the pharmacy, there will be no balance. Your bill will come from your insurance. And you can also choose to opt out at any time. If you opt out, you will be going to sort of regular paying at the pharmacy. And the one thing about opting out is that you will still have to pay back whatever balance is left as a result of the deferred costs that you're trying to spread out over the whole year. These are the formulas that Medicare uses in the M3P. You could say to yourself, well, if this is just a distribution of cost, then whatever my cost is for the year, they'll divide it up evenly over the number of months. That's not true. There's two formulas. They use one formula to calculate the first month on the M3P, and then a second formula you see at the bottom to calculate the rest of the months on the M3P. And there's a number of inputs into these formulas, as you can see. So your cost will shift a little bit throughout the year. It depends on how much balance is deferred that you're still paying off. It depends on if you're going to the pharmacy to pick up new medicine and there's a new incurred cost. And it also depends on how many months are remaining in the year. I will say, if you're someone that thinks spreading out the cost instead of paying a lot up front, you're someone that thinks that's beneficial, try to enroll in this as early as you can in the year, because you'll have the longer amount of time to spread the cost out. So you'll have more even, manageable payments over the whole year. Versus if you enroll in the back half of the year, first of all, you've probably paid a lot already, but also there's only so many months to spread the cost out. This is two examples of where it's beneficial and not beneficial. The top is when the M3P is not beneficial. If you're someone that has low cost at the pharmacy, it's pretty stable every month, you don't have any issues going to the pharmacy and paying for the medicine, don't do the M3P. Just keep doing what you're doing if it's manageable. If you do the M3P, in this case, it's not designed for it, and the formula destabilizes your payment. You end up deferring some cost in the beginning and having to make it all up in the end. But if you're someone, for example, you take generic drugs and Ozempic, a high-cost brand name drug, then actually it could be beneficial because in that scenario, your first fill could be $700 as it is in this example. That's deductible plus your coinsurance. And then you have a couple of $300, $300 payments before you hit the cap, and then it's zero. So that's a lot up front, especially that first payment, and not a lot on the back end. If you want more even coverage under the M3P formulas, that first bill would only be $175. You defer $600 to spread out over the rest of the year. And as you can see by the yellow line on the bottom, the rest of the year it's not an even payment, at least not until you hit your cap, but it stays between $100 and $200. So that might be maybe more within your plans or just more sort of in the financial style you're willing to pay. So keep an eye on the M3P, and if you think it will be helpful for you, again, it doesn't save you money, but it does help distribute the cost, which a lot of the times can be helpful, especially if you're picking up multiple brand name drugs and you have a high deductible. With that, I think there's a number of questions. I'm happy to stay a little extra to answer them. And thank you so much for joining us. Let's take a look at some of
Yeah,
these questions.
I can help you, Michael. At the very
Yeah,
top, there's what the first one was the if a drug is not covered, like it's a brand name and there's no generic equivalent available that is effective for me, does the cost of the drug contribute to the 2100 yearly max?
that's a great question. So the 2100 yearly max only applies to covered drugs because if you pay for a drug sort of cash price outside of insurance, insurance doesn't even know about it. So it will not be applied uh, towards that $2,100. In that case, you're using a brand name drug, so there's no generic equivalent, there's no low cost equivalent. And that drug, the drug they're asking you to take or covering is not one that works for you, but the one that you want to take is not covered. I would see if it's possible through maybe like a prior authorization with your doctor to get approved for that drug. It'd probably be a little bit of a painstaking process, but worth it because yes, if you're not getting it through insurance, it's not going to the 2100 and you're going to be stuck paying a lot per month every month. Maybe possibly $10,000 over the year.
Yeah. Thank you. Yeah, I think you answered this next one. It was whether the Omnipod like would be covered under Part B, um,
Yeah,
or yeah,
Omnipod should be under Part D. It should be under Part D. I will
D
say
is in
Farm
dog.
D
D is
as
in
in
dog.
dog. Yeah.
Okay,
It is
so
one of
D.
those rare pieces of equipment covered under Part D. A lot of most of other equipment, and I think almost every other insulin pump is Part B as in boy.
Okay, good. Um, the next one in order was regarding the Dexcom G7. Did you say that it should be ordered from a durable medical equipment provider rather than from a pharmacy for a type 1 diabetic insulin pump user?
To be honest, I don't deal with Dexcom prescriptions for type 1 insulin pumps all the time or very frequently at all. I will say it's still going to be covered under Part B. My general experience is that durable medical equipment suppliers, because they only deal with medical equipment and they basically only deal with Part B, handle the paperwork that's required for coverage much more efficiently. That is my experience in my practice. Now, that's not to say that's always the case. I've definitely had a few patients that they don't want to do a supplier, they want to go to the pharmacy, pick it up. It can be done, no question about it. It can be done. But usually there's longer delays. The reauthorization is a harder process. Typically, the suppliers are more on top of it. So my recommendation is to go through a supplier. Now, if you have a good thing going through pharmacy, don't let me mess it up. But the supplier usually, in my experience, is better.
Yeah. And I see one more here. Do these changes apply to managed care plans like Kaiser, for example?
Yeah, any plan, any Part D plan that's Medicare has to abide by these rules. They can choose, the plans can choose how they cover things in the sense that I can have a $0 to $615 deductible. It can't be more than 615, but it could be 400. They can choose how much to charge you per month for the premium. They can choose what's on their formulary to some extent, how much they want to cover it to some extent. But like the three-phase rule, the catastrophic coverage cap, all of that is governed under the Part D rules.
Great. Any other questions? I'm looking at the chat. Uh, yes, thank you. All really good information. It seems almost a bit overwhelming, but it's nice that you're able to break it down. There's so many exciting changes with diabetes, and both with how we test our sugars and the medications we're using to treat it. So, um, glad we have Michael to review this for us. Hopefully, he'll probably have to come back next year and do the same thing because it'll be all different because it's forever changing, right, Michael? So,
Right.
um, I think we're gonna close it off here. Thank you guys for attending. Thank you for Michael for the engaging talk. The recording will be posted next week in the Health Library under Lectures and Events, specifically under the Diabetes Care Program. So you can rewatch, rewind, find the topics you didn't quite get, and then we'll see you next month. Reminder that we're here the second Thursday of each month at 5 p.m. And so big applause for Michael, and we'll see you next time, guys.
Thank you, everyone. Thank you, Crystal.
Bye.